Hi everyone, welcome to the final Forefront seminar of this series. My name's Dr. Claire Jonas and I'm one of the Research Communications Officer at Alzheimer's Society. I'm the host of the webinar today, and our speaker will be Dr. Mel Handley, who's one of our senior fellows at the University of Hertfordshire, and she's going to be talking about person-centred care in hospitals. Take it away, Mel.
Hi everyone, I'll just share my screen. So thank you very much for that introduction, Claire. As you said, I'm a researcher at the University of Hertfordshire, and I've been involved in a number of projects looking at services and care for people with dementia in different settings. So today I am going to focus on my work in hospital settings and looking at the role of person-centred care there. So first I'm going to give some background information and then I'm going to start talking about the current study that I'm working on, the CONNECT study, which is funded by Alzheimer's Society. So some of you may well be familiar with this information, but I thought it'd be useful to share it anyway. So hospital staff are very likely to work with people with dementia during their everyday work. Estimates suggest that 1 in 4 people who are in hospital are people with the dementia. And people with dementia are admitted to hospital for a wide variety of reasons. So it's not necessarily related to their dementia. It could be because of other long-term conditions that they have. It could be related to an accident or an incident that they might have had, for example, if they've broken a hip. It might be related to complications from an acute condition, such as an infection. As such, people with dementia will be cared for across a wide range of specialities. Different hospital wards may well be looking to address their primary reason for admission, and as such hospital staff will be focusing on that primary reason, and with their dementia care needs being a secondary consideration. During a hospital stay, researchers found that people with dementia are at higher risk of having complications. So they may have a fall while they're in hospital. This may extend their hospital stay while they're being treated for the fall, as well as their original reason for the admission. And hospital admissions can also be extended due to complications with discharge processes. So the person might be recognised as being medically fit for discharge, but actually the care package or the care support that they need isn't in place to help them to go back to the community. And I think it's fair to say that for most people, the experience of being admitted to hospital is quite quite a concerning experience, and for people with dementia this can be particularly frightening and disorientating, as they might have trouble understanding where they are and why they've been admitted. They're definitely going to be feeling unwell, and they might have trouble communicating their experience of pain accurately, so where they're feeling pain and how that pain is feeling to them. Hospital environments are particularly busy and noisy environments generally, and they will be having multiple staff involved in their care throughout the admission process and while they're on the ward. This can mean that they're not necessarily understanding why people are involved in their care and what the interactions are about, as some of those will be extremely brief. This means that it's hugely important that they're able to have the support from either family members, friends, neighbours, or anyone who's involved in them in their day-to-day lives. This way they can help them to understand what's going on in the hospital process, but they can also reassure them, and they can provide hospital staff with information that's going to be key to supporting the person well. However, this has been something that has been complicated due to COVID. In the very early months of the COVID pandemic, hospitals restricted visits, and this was something that particularly affected people living with dementia, and certainly the Alzheimer's Society and John's campaign really tried to help for the access to be improved for people supporting people with dementia. It not only had implications for people with dementia, but also for staff who were supporting them. The staff themselves, they were having to put in place additional infection control requirements, and also covering the work of colleagues who have maybe gone off sick with COVID or were having to self-isolate. And they're also being redeployed around the hospitals to different wards, so wards they weren't necessarily familiar with, and working with colleagues in specialities that they weren't all as used to working with. The requirements to wear masks and other items of PPE could have an impact on how communication took place with people with dementia and staff, and this might have intensified some anxious feelings around being in hospital. And staff also needed to enforce social distancing measures. So for people who had COVID or were close contacts of people with COVID, they might need to restrict the areas of the hospital that they could go to. And for people with dementia, this could be difficult for them to understand that they needed to stay in a particular place and the reasons for that. As a result of all these measures, there were implications to the care for people with dementia and how person-centred care could be used. So person-centred care itself, it has its foundations in the work of Tom Kitwood and has been developed by people like Dawn Brooker into the VIPs framework. The core principles of person-centred care are that staff understand care from the viewpoint of the person, that they're able to use it to anticipate and address the fundamental psychological needs of the person. So they are framed by Tom Kitwood as attachment, comfort, identity, inclusion and occupation. And it's also for staff who understand dementia and are able to use a person-centred approach. They're able to recognise that people with dementia will communicate their needs differently. So it won't be necessarily what they say, it'd be how they say it and the emotion behind what they're saying. But also they might have particular behaviours that are trying to express an unmet need. In terms of applying person-centred care in hospitals, this can be quite challenging. There are challenges around getting to know the person. People are admitted without some of that personal information. The focus has been on collecting the clinical history. People aren't expected to stay in hospitals for a long time. And staff might have difficulty getting to know the things that are important that can make a difference to a person's care. Supporting independence can be challenging for staff when they recognise that the person is at risk, for example, at risk of having a fall or something, and they're working in a very risk-averse environment as well. So this means that staff are very conscious of the consequences of something happening and would take a more restrictive approach to care. Supporting independence can be challenging, and but also there are many competing demands that staff might have. They're not just focused on the one person or a small group of people, but they also have the daily work and tasks that need to happen within the ward to ensure that the ward work goes smoothly. So these challenges are well known within the research. However, evidence suggests that person-centred approaches are possible, and there are particular instances around the importance of those in the moment interactions for helping people to be reassured and to relax them and just to generally treat people as humans. There are also evidence that some staff are better at identifying where opportunities can be to provide person-centred care when they're performing other care tasks. So hospitals and hospital organisations have developed a number of different resources to help staff overcome some of these challenges. So, for example, there's been adaptations to environments. These can range from things like signage to help people orientate themselves to time and place. It can be around areas of wards so that they're less clinical and provide people with some familiar objects to help them feel more in a familiar place. And some wards have had big redesigns so that they've been able to increase the areas for people to walk around safely, and also to encourage areas of communal sitting, so for people to sit together, for patients to sit together with staff while they're having their meals, for example, or to be part of an activity. There are also resources for getting to know people and getting to know things outside of those clinical history taking. So, for example, Alzheimer's Society's This Is Me booklet is used to gain information from the person and from their supporter about what's important to them, and things might be their name, their preferred name, or something around what they like to drink or what they don't like to eat that's important. And there are also types of resources to help identify that a person has dementia. And this can be controversial for people, but things like wristbands and magnets used on patient boards can be a way for staff to identify that a person has dementia, and they may need to spend more time with them, may need to adapt to the way that they communicate with people. And this can be particularly important for those staff who very briefly are with the person and maybe only for a one-time, so potentially people like phlebotomists who are taking a blood sample. So all of these interventions are supplemented and with training in dementia awareness. And for staff who spend more time with people with dementia, there are recommendations that they have more in-depth training, and the Health Education England has a set of dementia training standards that they can be used. However, despite all of these resources, dementia care can still be variable, and it often depends on the skills and the motivations of the individual staff members as to whether or not a person-centred approach is used, rather than something that is embedded as part of the expectations of standard practice. So this leads to the question, is a consistent approach possible? So findings from my PhD suggested that if organisational and staff priorities were to align with a person's priorities, then it might be possible to have a person-centred approach. And this is really the finding that underpins the basis for the CONNECT study. So the CONNECT study is funded by the Alzheimer's Society. It's a 2-year project, and we're at the University of Hertfordshire. We're working with colleagues from Leeds Beckett University and University of Nottingham. And what we're hoping to do is to understand that if we were to develop an intervention that focused on a priority area of care for staff. So for the CONNECT study, we're focusing on managing a person's risk of harm. If we were to develop an intervention on that, would it be possible to support peer learning? Would it be possible to demonstrate to staff that person-centred dementia care in acute settings is possible? And can staff then understand that dementia care is a skilled and important part of their work? So we're going to be doing this by focusing on an activity that is common across hospitals in the UK. The use of constant observation is a practice that manages a person's risk by assigning a member of staff to support them and to observe them and monitor their needs for care. So this can be done as one-to-one support, which is commonly termed as specialing, and the person who's specialing might have to be in arm's length of the person. They might be able to sit further away and interact with them at a distance, as well as being close to them when needed. There are also ways of providing a constant observation to more than one patient. So that would be in the case of bay nursing, and by cohorting people who have similar needs in one bay area. So typically this would be 4 to 6 people sharing a bed bay area, but hospital ward designs differ and the configurations are different. So it would depend on how the ward is set up as to how many people the member of staff might be responsible for. In terms of people with dementia who are in receipt of this type of activity, mostly they would be assigned it because there's identified as a risk of fault. And so this would be partly because of not recognising that there was a safety issue around getting out of bed and walking around on their own, that they would do this before they were able to contact a member of staff to help them to walk around the ward. So in this way, the member of staff can see that the person is wanting to get out of bed or walk around, and they can go and they can help them to do that. There are other reasons why a person might be assigned to constant observation. So for example, if they have IV fluids or medications, they might find this uncomfortable and distressing and be trying to remove the tubes. So a person might be assigned to support them with that. And also people might be trying to leave the ward area before it's safe for them to do so. So people might be assigned to a constant observation for that reason. There are a number of other reasons, but those would be the main ones. For staff, they have to work with these multiple reasons. They would need to be able to prioritise what the needs were of the person and address them as necessary, while also being aware of what else was going on in the ward. So it's how they understand what is important to work with and how they're going to address that. And quite often the staff who are allocated to this type of activity, they would be the healthcare assistants or the clinical support workers, they might be student nurses, or they might be agency staff. So their particular experiences of dementia care and how they understand what's needed to support a person will vary quite a lot. They might also interpret what is expected of them during this activity differently. So they might see it as an opportunity for supporting and enhancing a person's care. They might see it as a need to restrict the activity that a person is involved in. So this would have an effect on whether the person finds this a positive experience or not. So what we're doing with the CONNECT study is we're working with 3 different hospitals who have different ways of using the constant observation activity. In the first hospital, they have a team of staff who work across the hospital, are supported by a senior nurse who has expertise in dementia care, and they have additional training in dementia care and other aspects of their work. And they work across the hospital and can be allocated to different wards across the time of their shift. In the second hospital, they have one ward where the medical and mental health needs of patients with dementia can be addressed. This ward has a mixture of staff, so it has medical nursing staff as well as mental health nursing staff, and they're able to all be allocated to constant observation practices. We're also working with other wards in this hospital, just so that we get an understanding of how it works in the more typically staffed hospitals and where people with dementia are admitted for their primary reason of admission. And in the third hospital, they tend to employ agency staff to perform the constant observation practices. So unlike ward staff, these particular group of agency staff would not get involved in things like personal care. So they wouldn't support someone with washing or going to the toilet. They would need to involve a member of staff to do that. So in all the hospitals, these constant observation activities, while they may have some differences, they also always involve ward staff generally, where the constant observation can't be covered by the additional staff. And currently what we're doing is we're mapping how that works in the hospitals, and we're doing this in a number of ways. So we have research observations taking place. We're looking at how constant observation takes place in the bed bays. We're also doing observations of different staff processes such as handovers and ward rounds to see how that feeds into what is understood to be the priorities for constant observation. We are conducting interviews with people with dementia, family and other supporters, and also with staff members. And we are conducting surveys of how often constant observation takes place with people with dementia. So whether it's one-to-one support or whether it's a bay nursing type of activity, and the reasons why people have been assigned to those. And we're also looking at the documents around the constant observation. So things like documents that would be used for care planning, documents that were used for referrals, and also any policies that the hospitals have which are of relevance. So this information, along with a systematic review of interventions, focusing on what interventions could support constant observation practices, are going to help us to move into the co-design phase. So next year we move into this co-design phase, and we're going to be working with people with dementia, their supporters and staff across the 3 different hospital sites. So we've got a number of workshops planned, some which are site-specific workshops and some which are across the 3 sites. This is to acknowledge that there's going to be some context differences, and so there'll be local adaptations needed, but also to make sure that the broad overarching intervention is similarly developed and going to be implemented across the sites. So we're going to be holding these workshops online. Originally, we were hoping to do these face-to-face, partly because of the pandemic. This has moved to an online activity, but also for helping us to give the time for people to join and to make it more convenient for people, especially when it's the cross-site co-design, to support people to join that. And then once it's developed, we will be testing the feasibility to see if it's acceptable to staff, if they find it useful, and if it does actually make improvements to care for people with dementia. As to be expected, and as many research activities and general life, the pandemic has had an impact on the study and the research activities. So we were actually due to start this study in June 2020, and we had the pre-study meetings and everything was in place to get going with recruiting research fellows. And then a few weeks later, we went into the first national lockdown. So this, of course, meant that all visitors in hospitals were not allowed to go in, and all research activities were put on hold. In many ways, we're quite fortunate, really, that we hadn't started the research, because I think this would have added administrative complications. So we had quarterly meetings throughout the first year of the pandemic to see how we were going to adapt the research, and also to try and identify a point where it might be helpful to think about starting study setup. And a huge thank you to the Alzheimer's Society for supporting us during that time and allowing us to delay the start date of the research. When we did identify a good time to start, which was July of this year, we needed to go through some risk assessments which were COVID related, to ensure the safety of the researchers and also the people they'd come into contact with at the hospitals. So that was about committing to following local and national guidance around things like the use of PPE and hygiene requirements, committing to taking twice weekly lateral flow tests before visiting sites, and following any guidance around self-isolation. So I'm pleased to say that none of the researchers involved in data collection have contracted COVID as part of the data collection, or as far as I'm aware at all. And certainly when I visited one of the sites, the hospital itself felt like a very safe environment. The staff and the organisation have worked very hard to make those places extremely safe for people to visit. And one of the things that did strike me actually was how natural everyone felt wearing the face masks. So while there were concerns around face masks being a barrier to communication, particularly for people with dementia, certainly from what I observed, this didn't seem to have the impact that might have been suggested. It might have been that people are now more familiar with the use of face masks, and so it's not such a concern. In terms of the research itself, so I conducted research in hospital settings previously, and one of the things that I would have done to help build relationships and navigate the site and understand the routines of the environment would be just to spend time outside of formal research activities on the wards and in the hospital itself. There were restrictions on doing this, and so it did mean that actually those relationships with key supporters of the research needed to be conducted online. So having virtual conversations with them to understand who would be helpful to contact, and having them introduce us both virtually and arranging fixed points to go and meet these people. So fortunately, the discussions that we've had has demonstrated that people are interested in this research and are very happy to listen about it and be involved in some way, whether it's as a participant of an interview or an observation, or to join as part of the co-design team. And I think I can speak for the team in this to say we feel very privileged and humbled to have been working with staff who've been under such immense pressure for the last few years, and to still feel welcomed and listened to. So a thank you to our sites for that. So these are the references that have informed this presentation. And just to say thank you to the Alzheimer's Society for funding the project, and a thank you to the NIHR ARC East of England for supporting it. I don't know if there are any questions.
So just a reminder that you can ask Mel any questions by putting them in the Q&A or in the chat, and I will relay them to her. I've got a question to start with. Actually, I've got several questions now. I've got you here. So my background is not in care research at all. So I'm actually really curious about how person-centered care got started. Like, how were those principles developed? Could you talk a bit about that?
So that was back in the 1990s that Tom Kitt was doing work in care homes and recognising that there were some deficits in care, that people weren't being seen as people. And Tom Kitwood's background was as a psychologist, and so he was looking at the things that were important to people and how that could be something to focus on, how moving away from a sort of task-focused approach to care to something that was much more holistic and understood, and put the person at the centre of the care process. So I can't remember the exact phrase that he uses, but personhood is about bestowing sorry, I can't remember.
Okay.
I can't remember that particular phrase, which is annoying, but yeah, it's about really understanding care from the person's point of view and what's important to them.
Excellent, thank you. Oh, we've got a question that's come in from Jan Leeks. How easy has it been for staff to attend the workshops?
So we're not starting the workshops until next year. So we will be very flexible in how we approach the use of the workshops. So we will have fixed times for the workshops to take place, but we're also offering to meet on an individual basis when it's easier for staff to meet, and if that's something, if we're allowed back into the hospitals once Omicron's done its stuff, then we would hope to be able to offer opportunities within their time at work. So if they were able to grab some sessions, we would be making sure that any materials we develop, so that they can have a look at them and absorb the materials, are very easy to digest, and what we're asking of the materials is very clear, so that it doesn't necessarily have to be a long discussion. It can be that they feel that this is what's important, and perhaps they may not feel a meeting's necessary. Perhaps feedback via an email might be just as useful.
Yeah, of course, we're seeing a lot of these kinds of adjustments in response to COVID across all of the research projects for funding, as you might imagine. So it's really nice to see actually the sort of the variety of things that people come up with, and the sort of inventiveness in some cases of the solutions that people come up with. So
absolutely,
thank you.
Absolutely.
Jan has also said the end of the phrase you were searching for is bestows from one person to another.
Yes, thank you, Jan. Thank you. I'm so embarrassed that I forgot that.
I think it's one of those things, isn't it? Just words will go out of your head sometimes. Okay, so we've got several questions in the chat. Excellent, thank you everyone. So Rebecca says, this is really fascinating and important research. I wonder where you're observing within NHS sites. Is it mainly older people's care wards?
So we've got several different types of wards. So we do predominantly have older people's care wards, but we've also got stroke wards. We have got an assessment ward, so that would be where someone just comes in and may spend a few days in there, but before they go on to either another ward to be admitted for longer term care, or whether they're discharged back out into the community. And there is another type of ward. Oh, sorry, yes, and so orthopaedic wards as well, yes.
Thank you. Okay, we have one from Jurai. I hope I am pronouncing your name correctly there. They say, thanks. Do you know of any training package that is out there up to date, that is evidence-based for training or refreshing staff in person-centered care, with a chance for staff to role play, etc.? Easily digestible materials would be great.
Oh, well, offhand, no, I don't. I think that Dementia UK probably have, so that's with the Admiral nurses, they would probably have some materials that are available. I did see something very recently around experiential care, and so perhaps if you like, I could see if I can find that and send on details. It's
yes, absolutely. Jurai, if you should be able to find Mel's contact details at the profile that Adam posted earlier in the chat. So you could drop a message, and hopefully you'll be able to sort something out that way. So Ileana, so not a question here, just a reference to something else. So great presentation, thank you. Your research aims reflect key messages of a recently published policy brief by the University of Exeter linked to improvement of dementia care in hospitals. And then there's a link there if anyone's interested in reading that.
Fantastic. Yes, so that's a great project, that is, yeah.
Yeah. Fantastic. Thank you, Jurai. Okay, we've got the email there in the chat for you, Mel. Okay, something else coming through the Q&A. So from my colleague Hayley, it's really good to hear how positive and warm the sites have been towards the research. Do you have any ideas of how you would like to see the intervention implemented? I know this is a long way off and will depend on the results of the research, but it seems like you have the buy-in from the outset.
Yeah. So do you mean in terms of the look of the intervention? If it's in terms of the look of the intervention, I think there's going to be several strands to it. So I think there's going to be something that can be used during the interactions with the member of staff and the person with dementia. So whether it's about building up the knowledge of what's important and picking out things that have taken place over the day to help inform other colleagues' care, and perhaps utilising things that are already in the environment, so the patient board, so writing up things that are important there and making sure that's someone's responsibility to do that. I think there's also going to be things around how structuring handovers prioritises people's personal needs alongside their medical concerns. So for example, if huddles were taking place, that the goals for person's care are set out in that respect, and potentially providing opportunities for staff to share their good experiences, or even the challenges, but using it in a way that's problem solving rather than just a moan.
I'm with you.
But I think there will be several strands, and there'll probably be other ideas that come out when we go into those co-design.
Absolutely. Again, feel free to send any questions into the chat or the Q&A. I think that's it from other people at the moment, but I had another question. I love questions. So I can imagine doing something like constant observation would probably take quite an emotional tax on the staff, and sometimes a physical tax as well. Is that something you're sort of investigating within this project? Could you tell me a bit more about that?
Yes, so certainly something that's coming through from the interviews is staff's experiences of how they are experiencing those situations, and things that have been helpful to them. So certainly I know at one site there are opportunities for staff to have a debrief of those challenging situations. I don't know whether it's something that's common to all of the sites, and certainly where agency staff are involved, that might be something that's far more difficult to organise. It's certainly something that is part of that type of activity. Yeah. So I think there will be something that we need to somehow address.
Yeah, definitely. I'm just, I remember you saying this. I was thinking, sort of imagining myself doing that work, and I thought, gosh, that would be exhausting.
Yeah, and certainly it's recognised as exhausting, both by the staff who are doing it and by the staff who don't get involved in that work, and express well, the gratitude that they're not the ones doing that activity, and admiration for them.
Yeah, definitely. We've got a related question that's coming from Rebecca. Why do you think there are different approaches to constant observation practices across NHS trusts? It seems like a wide variation.
So I think partly it's down to how the constant observation is resourced. So I know in one of the sites there was a recognition that there had been historically a reliance on agency staff, and they wondered if they could look at making it more cost effective by bringing that sort of activity in-house, and being able to organise it themselves. And then that way as well, they had control over how people were trained and how people were monitored, and the standard of care that was expected. In terms of other, for some hospitals, potentially they may not have looked at how that could be addressed within their own workforce, and potentially it might not be that within the local area that's a possibility. It might be that actually there is a preference for people to work through agencies, to have the flexibility of the time that they're working. And certainly in terms of how the specific ward is set up, that's quite a huge investment to make, and really needs to be led by someone who has a good vision for how that can be set up and maintained and sustained.
Absolutely. Okay. I'm just looking to see no more questions have come in. Again, feel free to type them into the Q&A or in the chat if you would like to, anyone. I had one final question from me. It's one that I'm struggling to put together. So you said with person-centered care, it's sort of an organisation's priorities matching a person's priorities. So I'm imagining there are situations in which you're in a single organisation, person-centered care is possible for some people, but not for others because of some people will be closer to the organisation's priorities. How do you cope with those kinds of situations?
Yeah, I think it's very difficult, and I think one of the things that came out from the PhD was the concerns that staff had around going against expectations of their role and of their organisation, and I think it takes a certain level of feeling authoritative in that situation that you can make that decision and go against what is the norm. It's a very difficult thing for people to do. I think it's certainly one of the reasons that we've focused on this constant observation was there's staff often feel under pressure time-wise in their ability to spend much time with patients and provide care in a way that they'd like to. And part of the argument for focusing on constant observation is that people are allocated that time to spend in that area with the people. Of course, the activity itself is there for a reason, because it's very difficult for those people who are in need of it. So actually, it's not just about having the time, it's about what the person needs and how you can support that person well. So it's it's challenging.
Thank you.
Hopefully we'll be able to find something that can
absolutely
make a difference.
I will cross my fingers. Not very scientific, but okay. I think we're just coming up to 1:15, but we have one final question here from Jurai. Do all your sites give staff the same degree of access to wellbeing and support? As during times of COVID particularly, maybe there could be emotional avoidance of getting to know people or getting close to people when they're feeling burned out, etc. And that temptation to avoid might be outside of people's awareness. Gosh, that's a really tricky thing to deal with. What a great question.
That's a great question, and I think that sort of becomes one of the big issues that we'll be dealing with. I can't speak for what support there is across the different sites. I do know for one particular team, they do have that access to that support. Whether they access it or not is another thing, because I think there can be difficulties in people raising their concerns, and they feel quite vulnerable to do that, and potentially expectations of what you're supposed to deal with in terms of a job and things. And certainly there are things like the Schwartz rounds which are used across hospitals. I'm not entirely sure whether the 3 sites we're working with are using those and to what degree, but I think those sorts of interventions are very helpful.
Absolutely. Funnily enough, I'm actually a Schwartz round facilitator. So one of the charities I have previously worked for adopted Schwartz rounds, and my goodness, they were so helpful. So yeah, absolutely, those are great. Just for anyone who's not familiar, Schwartz rounds are kind of forums where you can talk about the emotional impact of your work. So obviously in a hospital, that might be things varying from difficulties in engaging with someone to perhaps the death of a patient. Whereas in my work, it was more, someone perhaps phoning up the support line and we weren't able to help them or something like that. So you can have all different kinds of reasons why you might use a Schwartz round. Okay, thank you. that brings us to 1:15, so we will draw it to a close now. Thank you ever so much, Melanie. That was really interesting to get an insight into that work, and thank you for answering all of these questions as well.
That's okay. Thank you very much for having me.
Thanks, everyone.